Hi, everyone, and welcome to Fit for Fellowship, a survival guide for the first-year general cardiology fellow. I'm Megan.
And I'm Stacy.
And welcome back. We have Dr. Megan Kamath with us from UCLA going over complications of transplant. And thank you, Dr. Kamath, for that fantastic lecture. And we've already gotten multiple questions on that, so we really appreciate this.
Thank you.
Thanks so much for having me, and looking forward to helping answer any questions that come up.
Excellent. So let's dive right into the questions. So the first one has to do with the listing of patients on the transplant list and mechanical support. So this fellow asked, does the level of mechanical support, i.e. if a patient is P3 on Impella, matter towards listing?
That's a really good question. So just to go back for a moment and review, prior to 2018, we had a listing system that was fairly broad. And by that, I mean there were categories 1A, category 2, and category 7, essentially. And the 1A was those patients who were waiting in the hospital, listed for transplant. Your status 2s were those that were really outside of the hospital waiting outpatient, and status 7 were those that were temporarily too sick to transplant or inactive for any reason on the wait list. In October of 2018, the guidelines changed and it made it a 7 status system, really, with status 1 being those patients that were at the highest urgency for transplant, status 2 being right below that, status 3 being those with your single inotrope at high dose or dual inotropes at lower doses, status 4 being those patients who are maybe supported by inotropes but outside of the hospital, not needing invasive hemodynamic monitoring, also encompassing some of your restrictive cardiomyopathy types of patients, status 5 being your dual organs that can wait outside the hospital, and status 6 being really any candidate that is eligible for transplantation. Status 7, again, referring to that temporarily inactive or too sick to transplant situation. So to reference the fellow's question regarding the level of support, yes, different types of support do affect one's listing status. For example, if you're on VA ECMO, that gives you a status 1 listing versus if you are a patient who is supported by a balloon pump or an Impella, for example, that gives you a status 2 listing. But the specific settings as far as like P3 versus P7 on an Impella type of device, that doesn't really change your listing status. I think the other thing that's really important to note with respect to our durable mechanical circulatory support patients are that when a patient is supported with a durable left ventricular assist device, we automatically have a discretionary 30 days of status 3 time, because we recognize that those patients are sicker than some of our other heart failure patients. But once that 30 days of discretionary status 3 time is used, then they will end up being listed as status 4 for the remainder of the time that they're listed. So I think those are some important considerations to remember in the framework of this new listing system, or still somewhat new listing system, although it's been here for a couple of years.
Perfect. So the second question is about acute rejection. And so the question is, what is the time frame in which you would want to get the steroids on board? And how does that fit with timing a biopsy and then getting the results of the biopsy back?
Yeah, so those are really good questions too. And, to be frank, you're going to see different things at probably every institution that you train at, because it is something that's sometimes individualized depending on the timing that the patient comes in, depending on your availability of resources to get the biopsy done, all of those types of things. But in general, if you're concerned about acute rejection, it really doesn't hurt to give them a dose of steroids beforehand, because remember, you want to treat that patient who may be clinically unstable, potentially in cardiogenic shock. You need to do everything that you can to stabilize them. So if we have a patient coming in that we're concerned about acute rejection and we're not for whatever reason, able to get a biopsy very urgently, then it's okay. You can give them a dose of steroids. You're right that it may slightly lower the yield of a biopsy if rejection is patchy, but usually if they're in a situation where they've got severe rejection, you're probably going to catch it anyway with getting enough biopsy samples. Remember, the size of the biopsy samples that we're taking are about the size of a pinhead. So that's a really important thing to remember too, is that you want to be getting adequate sample. And so that's something that you'll learn as you go forth and you learn from the heart failure faculty at each institution, but taking adequate sample is important. Also measuring their hemodynamics, understanding their clinical presentation, right, as well, and how the patient is presenting in terms of how far are they out from transplant. The closer they are to transplant, the more likely that you're going to think about rejection, on your differential. And certainly rejection can present with very vague symptoms. So just to take a moment to step back and think about it, we've had patients present with rejection from anything with shortness of breath to abdominal pain to atrial arrhythmias being very common. There's often an old saying that I think one of my mentors used to say that, if it's a post-transplant patient who's fairly recent with atrial arrhythmias, you've got to think about rejection until proven otherwise. So I think those are some of the things that I would think about. And of course, to realize that your goal is to try to stabilize the patient in this process. And if you need to give them the steroids to do so before you do the biopsy, then, sometimes we end up being in that situation where we'll go ahead and do that.
Fantastic. The next question has to do with screening for CAV.
Sure.
So the question is, when would you consider assessing for CAV early? Or when would you consider doing a diagnostic left heart cath to assess for that early in a patient?
Yeah, that's a great question too. You guys are really enthusiastic and excited about your training, which is great to see. So each institution may do this a little bit differently, but I can speak to how our protocol here at UCLA is, and I would imagine that it's probably fairly similar. So for our patients post-transplant, we do a baseline angiogram at 6 weeks post-transplant. And then our surveillance protocol is after that at 1 year intervals for years 1 through 5. And so we do a baseline at 6 weeks, then year 1, 2, 3, 4, and then 5. One thing to also note is that when you're in the process of accepting a potential organ for a recipient, usually depending on the age of the donor and the circumstances surrounding the donor's death, you may have an angiogram from that as well, which can be really helpful to understand the need to do a angiogram maybe sooner or later, maybe influenced by that as well. But in general, I would say in our institution, 6 weeks post-transplant is their initial baseline angiogram. And then the timing of that, the angiograms afterwards really depend on what we see on the first angiogram. Remember a couple other things that are really important regarding the angiogram grading criteria for CAV is that we really use intravascular ultrasound, and we look at the intimal thickness of the blood vessels, coronary arteries, when we are assessing the degree of CAV. And I think in my presentation, I referenced a really nice schematic that goes over the criteria for grade 1, grade 2, grade 3 CAV. So that's something to definitely keep in mind when you're on your cath lab rotations, when you have a patient that's coming in for a surveillance angiogram.
Thank you. So next question is about actually tachycardia following heart transplant. So it's common, or oftentimes we'll find patients are tachycardic perhaps after transplant. And the question is really how tachycardic is too tachycardic? At what point do you need to intervene, and are you worried?
Yeah, so Patients that undergo transplant are denervated. And so you do expect to some degree that they will have tachycardia. And so usually we say, between 90 and 110 beats per minute is somewhere in the normal range. There may be situational reasons acutely post-transplant where a patient is going to be more tachycardic than that. For example, let's say the patient is in pain after you have extubated them and they're just starting to recover and get back into sort of their rehabilitation post-transplant. You may see their heart rate go up more than that 110 mark, and it may not be something that you need to be concerned about. But overall, I would say, I think looking at the clinical context for why the patient is tachycardic or why the patient may be more tachycardic than you would expect is an important thing. Also, going back to the basics, getting your 12-lead EKG, making sure that you're looking at whether the rhythm is truly sinus tachycardia or not. A lot of times these patients are in the ICU. You may have them on pacing initially, post-operatively. And so getting an underlying rhythm, testing the thresholds on your devices, knowing, electrically what's happening is really helpful too. But I would, as I mentioned, I'm not sure that I would be too concerned if there's a little bit of change, especially early on, because there may be other alternative underlying reasons for it. So make sure to take the entire clinical context of the patient and their time course post-transplant when you're concerned about the tachycardia.
Fantastic. The last question that we have has to do with graft dysfunction. So the fellow had mentioned something that they had heard about called nonspecific graft dysfunction. And the question is, when would you consider this and what do we do for it?
That's a really great question as well. And I think that, with all of the multimodality imaging resources that we have, we often take advantage of those types of things in that situation where we're trying to understand what is the cause of this. We certainly, in a transplant patient, first and foremost, want to make sure that there's no rejection type of etiology. We make sure that from a preventative medicine standpoint, we're treating them for the possibility of CAV by giving them aspirin and statin. We're making sure that they're on appropriate immunosuppression to reduce the risk of them developing complications. But there are sometimes situations where patients do develop this, concern for graft dysfunction that's somewhat unexplained. And then that's when we really turn to other imaging etiologies. For example, things like cardiac MRI may be helpful to really understand why that's the case. And for example, in one patient, we were able to realize with cardiac MRI that there was a concern for vasculopathy that really hadn't been picked up on angiogram. So there are situations like that, and I would say that's where we really turn to a multidisciplinary approach for each of these patients. And I think it's hard to often make a generalization about transplant patients because everybody is so unique. And a lot of times, even though we follow general guidelines as far as immunosuppression and treatment goes, there are definitely some nuanced and tailored approaches, especially when it comes to things like desensitization or immunosuppression modification regimens or following the patient post-transplant. But, I think making sure that you're following them in a very comprehensive way can be a really helpful first place to start when you come across something like this.
Thank you so much.
Yeah, no problem.
Sorry, was needed. Thank you again, Dr. Kamath. We really appreciate this. And again, excellent lecture and excellent Q&A as well.
My pleasure. Let me know if you have any further questions. I think you guys have my email address and I'm happy to answer anything else that comes up.
You definitely will. And just thank you again for just even taking the time and the effort to teach, and hope you know just how the fellows really, really appreciate you.
Oh, well, we appreciate you guys. You guys are the future of cardiology. So it's our jobs to help you out.
Well, thank you again. And for our viewers, our next and last actually boot camp session is next week with Dr. Daniele. So we look forward to seeing you all then, and hope you have a good week.